Good day and welcome to today's webinar, Trauma Training in a Double South to North Collaboration, Powerful Lessons from a Unique One-Year Transatlantic Clinical Experience, hosted by the American College of Surgeons International Relations Committee. My name is Jessie Romance. I am one of the committee administrators for the IRC. It is my pleasure to introduce our moderator for today's webinar, Dr. Juan Carlos Puyana. Dr. Puyana is a trauma and acute care surgeon, a global health educator, a clinical investigator, and an international mentor. He has recently been appointed as the O'Brien Chair of Global Surgery, where he is leading the Institute of Global Surgery at the Royal College of Surgeons in Ireland, the University of Medicine and Health Sciences. The IGS is the premier global health institute working on advancing capacity building in surgery and empowering local surgical societies to advance their educational curriculums in their effort to improve access to quality surgical care in sub-Saharan Africa and beyond. With that, I will now turn it over to Dr. Puyana. Dr. Puyana.
Good afternoon and good morning to everyone. Thank you, Jessie, for the opportunity to moderate this very interesting panel. Thank you, everyone, for joining us today for the American College of Surgeons International Relations Committee, a webinar on trauma training in a double South to North collaboration. Powerful lessons from a unique one-year transatlantic experience. We're joined by Drs. Isadora Frick de la Maza and Drs. Catherine Chu. Today, Dr. Frick de la Maza will share her experiences. Then Dr. Chu and I will provide a commentary on Dr. Frick de la Maza's presentation and her journey that we are very excited to present to you today. As you probably expect, you will be seeing a trauma surgery presentation, so there will be some pictures of real trauma in the real world. At the end, we'll be happy to address some of the questions and we'll have some closing remarks by the panelists. With that saying, I think I'm going to move directly to introduce Dr. Frick de la Maza. It is my pleasure to welcome her. Dr. Frick de la Maza is a senior resident in general surgery from the Université Catholique de Louvain, pardon my French, in Brussels, Belgium, with a great interest in trauma, global surgery, and the practice of medicine in resource-limited environments. She is now completing her 5th year of a surgical residency program, and she's now overseas. This last year, actually, the reason of the presentation, she will share with us the first 6 months that she spent in Colombia, and then the following 6 months that she spent in South Africa. These were at 2 major trauma centers with high volume, a little different one from each other, as the criteria are not the same for Colombia or South Africa. But this is one of the things we will learn from Isadora. This is a double international trauma training, and it's the first ever completed in a residency program for any resident in Europe. So I'm very excited to listen to Dr. Frick de la Maza, and I will hand it to Isadora for this presentation. Thank you very much.
Thank you very much, Prof. I will now share my screen. So thank you very much, Professor Puyana, for introducing me and joining me today alongside with Professor Chu on this webinar on global surgery and trauma training. I also want to thank the American College of Surgeons for organizing and supporting this webinar through the International Relations Committee. I must say I feel very humbled to be invited today to share with you this incredible journey I've been living this year overseas in Colombia and South Africa. My presentation today will be structured as well. As you can see here on the PowerPoint, I will start by answering the why. Why, as a surgical resident coming from Europe, I decided to go overseas for a year out of my comfort zone and work as a surgical resident in 2 very different care settings consecutively. and also the reason why I think this webinar can be of great value for the Assembly today. I will then illustrate what I've learned during this truly global surgical training experience overseas, and all the powerful and unique lessons that Kaylee and Cape Town taught me so far. I will then conclude with the how this can be of value for our international surgical community and how it can be achieved. Before I start, I would like to emphasize that this presentation is based on my experience, so there may be bias. Obviously, what I will cover in the next 15 minutes cannot, and I won't pretend it to be exhaustive. Contrary to the mentors accompanying me today, Professor Puyana and Professor Xu, I am just at the beginning of my journey in global surgery and trauma training. But for those of you who are interested in deepening their knowledge in that area and don't know where to start, I've put here on the slides the article written by the Lancet Commission in 2015, and who is considered by many as the Bible to start. If you don't know where to start and what to read, first begin with this article. It's of great value. Finally, I also would like to emphasize that the photos I'm sharing with you today serve their didactic purpose and are treated with as much respect as the patient I had the courtesy to take the picture from, and the settings here mentioned in my presentation. Thank you for that. When invited by the American College of Surgeons to do this presentation, the first thing I asked myself was, how can I make a presentation with so many different attendees coming from very different care settings, from different countries, different continents? What do we share? What do we have in common? And actually, to respond to that question, it's the very same reason that why I went overseas in the first place. And that reason is that we are facing an increase in the trauma burden globally. And as surgeons, we always aim to offer the best expertise and the best quality of care possible to our patients. There are many different ways to define the burden of trauma. I decided to do it so by the means of the Global Peace Index, and it is written by the Institute for Economics and Peace, because it allows all of our country to be represented there in one graphic. But obviously there are many ways of defining the burden of trauma. And I think maybe some of you in the assembly will think, but why a resident coming from one of the top 20, as you can see, most peaceful country would be bothered with violence, the trauma burden, and would go to, should I say, more violent countries? And actually, it is because according to the same report, over the last 15 years, the world has become less peaceful. This is a tendency that has repeated itself over the last 15 years. So how can we prepare for that? What can we do? Well, we can train, we can get more exposure, and this is where the magic of global surgical training come to life, which is you can go and have the exposure and the training that your own setting wouldn't allow you to, because of the very inherent epidemiology of your country. And ideally, this global surgical training should work both ways, should be a bilateral collaboration. For example, I came to South Africa and to Colombia to get more expertise in trauma, because I don't see as much in my setting, but my setting has a great expertise, for example, in robotics or laparoscopic surgery, in endovascular techniques. So ideally, people from the other hemisphere should also be allowed and should come to our setting to learn as well, so that these collaboration really benefit each other. So that's why I left almost 1 year ago, and that journey actually began before that. It began 3 years ago when I contacted the two hospitals that I wanted to work at train at, because of the high volume of trauma patients they were dealing with every day. And on this photo, you can see my settings in Belgium. And almost 1 year ago from now, I left my sunny country thanks to the scholarship granted from a private organization, which is called Vocatio. And I landed first in Colombia in October. That's the picture on the left of the screen. And then in April, I arrived here at Tigerberg Hospital. And this is really the biggest statement maybe of my presentation. It is that 1 week in Cali and 1 week in Tigerberg and Cape Town allowed me to see more severe penetrating trauma than the previous 4 years of my residency program in Belgium all together. So I think this is quite, for me, it was very rewarding, and it makes so much sense to go there and to learn from this high volume center. So if you ask me what struck me the most when I was overseas in Cali and Cape Town, first, the severity and the high volume of trauma patients that come every day to these settings. They come very unstable. I've never seen so many stab wounds or gunshot wounds, never performed so many open procedures, resuscitative thoracotomies or sternotomies, open heart surgeries. Here on the right screen, it's a case from here in Cape Town, a blunt trauma with a complete diaphragm injury, and you can see the stomach is all the way up in the thorax. So these are very impressive, very severe injuries. Also, one fantastic thing in both of these settings was the teaching methodology, the pedagogy there. The consultants were very approachable. I've never experienced so many interesting ways of teaching. It was very stimulating, and they know a lot. Trauma surgeon actually can manage everything from A to Zeta. They can manage the primary assessment in the emergency room. They can obviously operate very well, very skilled surgeon, and they deal with all the ICU complications. They have all this intensive care training that, for example, in Belgium, as surgical residents, we don't rotate through that. So that was very interesting for me to learn. And another very, I must say, I was in awe of the adaptability and the craftsmanship that I've seen there, even when dealing with limited resources in a limited resource environment. If a plan A didn't work, then we go to plan B, never with panic, always with great calm. And for example, here on the first photo, we had to perform a sternotomy, but the electric sternotom was not working, so we had to do it manually. The second picture show actually how the pre-hospital care is also very well managed. You have a sucking chest wound, and it's managed also very properly. The last photo there shows it was a patient admitted here when I was in Cape Town not so long ago. He had a stab wound to the axillary artery, bleeding a lot, and they could manage it with putting a lot of Foley catheter inside. And at the end of the day, the patient stopped bleeding and was alive. But mostly, and maybe I think it comes when you live in such an environment, the resilience of the trauma staff, but also of the patient. That was very humbling for me. And the next case I want to show you is actually the most beautiful one and the most humbling one of my career so far. This is a patient, 40-year-old, living in the street, who arrived early in January during one of my night shifts. And he had sustained severe stab wounds to the precordial area and the right flank. He was very unstable. The FAST was positive. So he was tamponating, and we had to perform an emergency sternotomy and laparotomy. So we brought him directly to the operating room. The operation went well, so he was alive after it. We repaired what was damaged. But the problem and actually the difficulty when dealing with patient who comes from who live in the street and who are homeless is that they're often malnourished. And the malnourishment is a big problem for the postoperative recuperation and the postoperative period. And this patient actually had a very, very long recovery. We operated on him the first time in January. And when I left Cali at the end of my rotation there by end of March, he was still in the ICU, still doing not very well. And I must say, to be honest with you, I didn't think he could make it. But the trauma team there never stopped believing in this patient. They always gave him the best care possible until the end. And the last photo is very beautiful because this photo actually was sent to me when I was here in South Africa in June, so a couple of months ago, and actually the patient survived. Which was again against all odds for me, but that this is something I will remember for the rest of my life, that actually you have to fight for your patient, you have to give them credit because you could be surprised in the way they will fight for their life, which is the case here. So obviously I've talked about the similarities between my experience in Cali and South Africa and in Cape Town. But let's be clear, there is no such thing as a global South. I think it's kind of reductive, maybe condescending to say, oh yeah, the global South, it is one entity there and everything is the same. No, quite the opposite. Actually, each hospital, each country, each continent has its own way of doing, and even in one city between two hospitals it can be very different. And one of these differences that I see between Cali and Cape Town is, for example, I've never seen so many gender-based violence patients coming to the hospital, which is actually women that got beaten very, very badly with injuries that could threaten their life, that I've never seen in Cali, for example. Another thing I learned that I've never heard of before coming to Cape Town was what they call the community assault. And you can see the picture on the left is one of those patients. That was when I was working at Kaelicha, which is a hospital located in a township. A township, for those of you who don't know, is the equivalent of the favelas or les bidonvilles en français, in French. And in these areas, actually, the people don't believe in the justice system. They don't believe in the police system, so they take justice in their own hands. And you get this kind of patient. And for me, when I first saw this patient, I didn't think it was so severe. For me, it was only bruises, but all the trauma team was very concerned with him, because this patient actually can die from this kind of wounds, because they develop crush syndrome, and if they are not reanimated properly, they kidney shut down, and it's a very poor prognosis. Other specificities in Cape Town, for example, is the role of the sangomas, which are the local healers, the shaman, as we can also say in the Latin America. But maybe that role can be explained later on with Professor Shu. And basically, the trauma systems are different. For example, in Cali, you have a trauma surgeon consultant on call 24/7 with the residents. And here in Cape Town, it's actually the resident who deal with the trauma patient at night. And they only call the consultant when they face a very difficult case, but otherwise they are the one who manage kind of everything. So that being said, what to expect, how to prepare for such an experience? Know that you will feel overwhelmed at some point, and it's completely normal. This picture was taken at the Cape of Good Hope, and as you can see, my face is everything but hopeful. But it's just to show you that it's normal coming to another country, not speaking the native language of there. For example, me, it's the English. I come from a French-speaking university, so at the beginning it's difficult to understand what's happening, but it's all right. You have to keep hope, keep on showing up, keep on going there every day with good intentions, and with time you will really get integrated by the team. They will trust you when they see your work ethic. They will trust you, and they will value your opinion. You will be part of the team. They will let you operate. They will let you assist, and they will take your opinion into consideration. So if you ask me, how can I prepare for that? When I first was on the plane to come to Cali and then to Cape Town, I was a bit nervous because, of course, I had done classes at ATLS. I had done also another class for trauma in France. But actually, everything you learn in textbooks or in med school, that's not what's going to make your experience the most fruitful. What is going to make your experience here valuable is the soft skills you will develop and have to develop. And these soft skills are only teachable when you are experiencing them. And that is, you have to adapt. You have to accept that it's another environment. There are other ways of doing things. Sometimes it takes more time, but you have to be resilient. You have to persevere. But mostly you have to be modest and respectful, because don't forget that you are the one going there. You are the one coming to their settings to learn from them. And obviously they know way more about you of how they manage things there. And if you think about it, it would be the same for us if one international resident would come to our setting. We wouldn't trust him directly for everything. It takes time, but with work ethic and team spirit, you will get there. A strong advice for me was also to have a strong community support and have mentors, because obviously at some points it is hard. You are out of your comfort zone, not speaking the language, and at the beginning everyone faces this challenge, but you will overcome them. I assure you. So I don't know if you remember, but at the beginning of my presentation I told you with this GPI report that the last 15 years I've shown a tendency that the world has become less peaceful. But according to the same group of experts, this is not a fatality, and we can break that circle of violence. And I quote, I will quote them now. Action in one country or one region can spill over into bordering regions and countries, leading to a virtuous circles. And where there is peace, healthcare can thrive. So I hope this presentation can be a little contribution towards that, can serve as a bridge for those of you attending this webinar and who want to cross their border and truly commit to be actor of a positive change globally. Because I promise you, there is so much to learn and so much to learn about one another, but also about yourself when you don't settle for less than the life you are capable of living. Thank you very much.
That was fantastic, Isadora. Thank you very much. I appreciate you sharing not only your experience, but that very introspective sort of individual view of what it's like to be there and to share during difficult cases with the people that welcome you. Before we have the panel present, I want to thank you for your presentation. And then for those who just joined us, I want to introduce Dr. Catherine Chu. She will provide us with a commentary after my introduction. She is the inaugural director of the Center for Global Surgery and a professor of global surgery at Stellenbosch University in South Africa. I've learned a lot about this university because they have a very strong collaboration with the Royal College of Surgeons here in Ireland. I'm very happy to learn about that. Dr. Chu is a fellow of the American College of Surgeons and a fellow of the American Society of Colorectal Surgeons. She received her undergraduate degree from Stanford University and completed her medical degree and general surgery residency at the University of California in San Francisco. She was a Fulbright scholar at the London School of Hygiene and Tropical Medicine, where she received a master's degree in public health in developing countries. She has co-authored over 100 peer-reviewed publications and holds several international grants to improve access to quality surgical care in sub-Saharan Africa. Dr. Chu is a board member of the Consortium of University for Global Health and the Transformation and Innovation Committee of Medicines and Frontiers. With that, I'd like to invite Dr. Chu to join us and give us tell us your impressions about Isadora's presentation and having her there visiting your facility and university. Thank you and welcome.
Thank you so much, Dr. Puyana, and thank you, Dr. Frick de la Masa, for such a fantastic presentation. I mean, I'm actually quite envious of you and wishing that I was also still a senior registrar and I could go to, and experience clinical rotations in other countries. So well done to you. I think you brought up several really interesting points. I think perhaps I would like to maybe give my own definition of what I think global surgery is and what I think are international surgical experiences. So, I think everybody has their own definition, but I think my definition of global surgery is improving surgical access through strengthening health systems. And when I think about the incredible experience that you've had as a trainee, I probably would first initially categorize it more as an international clinical experience for a trainee coming from one resource setting to visit two other ones that are completely different. And so I don't necessarily call that a global surgery experience right off the bat, but that doesn't diminish at all kind of the experience that you've had. I do reflect, though, that in a training capacity, when somebody from Belgium is training, how would they be able to contribute to global surgery in the future? That is, improving surgical access through health systems strengthening. And I think the first thing is to have international experiences like yourself, because I think it's very difficult to contribute to the global surgery movement if you don't experience firsthand health systems that are different from your own. And I think that you pointed out two really important benefits from an international clinical experience. Number one, seeing a very different pattern of the burden of disease, and you called it epidemiology, so yeah. And then also the management being very different in different places. And, you know, not just different from where you train in Belgium, but even Cali in Colombia and in Cape Town in South Africa. I think in your presentation you've highlighted, but also in our personal conversations, how different the management and the training is in the two different settings. So even though, as you rightly point out, you can't put all low and middle income countries into the global South basket, you can't also put the training experience as well, because I think some hospitals worldwide, some countries are better prepared to sort of do more formal training, while others, the experience might be beneficial because of the burden of disease that you see, the number of cases, the severe trauma. But, you know, I can say for one that Tigerberg, I don't think is necessarily set up for foreign trainees to come and slot into the system, as well as possibly Cali was in Colombia. That doesn't diminish from the benefits that you can take away from it, because you certainly, I think through your adaptability and resilience, could still take away a lot, but it might not be the formal training that one might be used to in Belgium, or even that you experienced in Colombia. So I think that, you know, doing an international rotation in a low middle income country doesn't mean you wouldn't get great formal teaching, but I think it does vary depending on which hospital you go to. And so for perhaps others listening on the call, I think do your research carefully. Talk to people that have rotated at the different hospitals, because the experience could be quite different. If you are happy to see and keep your eyes open, but not necessarily be, for example, on the call schedule, then I think a place like Tigerberg is highly beneficial. But if you want to sort of be slotted in a bit more, you know, Tigerberg is pretty crazy and they are very short staffed. And so they may not set up those rotations for international trainees as well as they could. I think that the other really important learning point that you have pointed out in your presentation is just that the social determinants of health and the cultural background of the people that experience trauma, so both intentional violence or road traffic accidents in different countries is different. And the way they seek care and reach care is also very different. So you pointed out, for example, community assault is a big issue. People in the community beating up someone who's raped someone else or who's stolen property from someone else. The community takes it into their own hands. And, you know, before I moved to South Africa, I had never experienced the amount of rhabdomyolysis, for example, from the crush syndrome that we see here. I think that's pretty unique. Also, you mentioned patients seeing sangomas or indigenous healers. I think that is fairly common in certain parts of Africa, for sure in South Africa. We just completed, for example, a survey of indigenous healers, or they're known as sangomas here, who do treat injury, and specifically, for example, broken bones. And really interestingly, 100% of them sent those patients to the healthcare system, the formal health system, to get x-rays. But 90% of those patients came back to them and were given an elixir or a potion to drink to heal the bones. And that was the preference of the patient as well as the preference of the healer in terms of treatment. And that's something quite interesting to be explored. In a place like Ghana and Nigeria, where traditional bone setters treat the majority of fractures, there have been collaborations between orthopedic surgeons who work in the formal health sector and the bone setters about how they can better work together. So rather than it being an antagonistic relationship, you know, rather than the orthopedic surgeons saying to the bone setters, just send us your patients, you're delaying them, they actually recognize that patients would seek care in their own communities first and wanted to better work together. And so one particular practice that was causing a lot of morbidity is putting chicken manure in open fractures by the bone setters. And so that was one kind of teaching that the orthopedic surgeons did, to say, can you please send us the open fractures and not put the manure in? And what the bone setters wanted was a better medical record system. They weren't actually keeping records of patients that would come back time and time again. And that's actually something that they wanted to learn from the doctors. And so it was a win-win in that setting, and that they were both communicating their needs. And so I think also in South Africa, we are now also doing a project to explore more how we can work with our Sangomas or indigenous healers. And you also, of course, pointed rates of gender-based violence that we also have in South Africa. And I think those things are important to explore in the upstream. But I will stop there with my comments. I did want to preempt the discussion later to ask you, after this amazing year, and it sounds like you've learned so much, what will you take back to your own practice when you go back? You're just about to finish soon. You're probably going to be looking for either a fellowship or your own job, perhaps doing research in the future. And how has this experience changed you, in particular through the lens of maybe participating in global surgery, in terms of, either capacity building or strengthening surgical systems in other countries? Thank you.
Thank you for your valuable insight, Catherine. I don't know if you want me to respond now, Professor Puyana, or we gather the
Yes, please
question.
respond now that the question is so fresh.
Okay. So what I will take back, obviously, I mentioned some of them in the presentation. I think in Belgium, we are only at the beginning, as I am at the beginning of this. There are a lot of definition of global surgery. You mentioned one. My view was maybe more an international collaboration system that I want to improve, because there is a lot we can learn, but my dream is to do it bilaterally. I would love to establish a setting where we can send people to South America or South Africa, and that's we have kind of a win-win, like you said, situation where they would also benefit from our experience, because otherwise it's too independent. I had to do it all by myself, and I think we need more structure for that. We need more relationships formalized with the universities, and I hope this webinar can contribute to that. And for the future, I would love to do more research about it, because I've learned so much, but the more I learned, the more I realize I have to learn way more, because every setting has its particularities. So I think I had a vision of global surgery. Wow, it's that one thing, but actually, as you mentioned, what is happening here in South Africa is not the same reality that in Namibia or in South America, Colombia versus Chile, where my parents come from. So it's very interesting also, and very humbling to know there is not such thing as a global surgery. It's more an international collaboration, and that's what I would love to establish. And in my setting, I think I have to create a mix with the mini invasive techniques that I usually deal with, and the trauma patient we have, which are mostly the trauma patient coming from MVA, motor vehicle accident, blunt trauma, and we have to be able to manage them with the plan A, which are mini invasive technique. But if that doesn't work, now I have all this knowledge of open techniques, and also the resilience and the calm. That's the most thing I've learned also by the trauma surgeon. They never panic, and it's a great skill for surgeon to be, to, in a stressful situation, your plan A, your plan B, you are the team leader, and that's something I could have never learned in books. So I will take home definitely.
Thank you very much, Catherine. I just want to add, Isadora and Catherine, thank you both for your presentation and for those insightful comments that you made at the end. I want to congratulate you for not only for the presentation, but for being there, for going there and sort of go out of your comfort zone and to explore the world in a different way. I think that if you look back we all know that global surgery means different things for different people, especially when you are not in high-income countries. The word global surgery for those in low-income countries means nothing. So we think that the most successful way of connecting with people and create valuable experiences is by developing these personal connections. And the best example of a personal connection is how the Royal College of Surgeons in Ireland began to work with COSEXA, two individuals who said, let's work together. And for those who are interested, they can read the history of the COSEXA collaboration with the Royal College. I'm going to move to the questions right now. I don't know if Jesse or anyone of our helpers in the seminar have a few questions from the audience. There is a comment that is sort of echoing what we said about what global means, but there is not a question in that. While we wait for other questions, then I'm going to go back to Isadora and say, what was it like to land there and sort of began to meet the team? I know that you have Spanish heritage from your family who grew up in Chile, and you speak Spanish. You also speak English and French. I wish I had all these many languages in my portfolio, but other people may not be able to enjoy these experiences because of language limitations and perhaps because of cultural limitations. So expand a little bit of what it was like to landing there and how that sort of move into being a part of the team, please.
So obviously, when you choose a rotation, and as Catherine, Professor Shu mentioned, you have to read a little, you have to do your little research. I think here I see more US residents coming from the Americas. When I was in Colombia, it was more about Spanish resident speaking Spanish. So obviously there is kind of this language connection that will impact your choice. English is not my native language. Thank you for saying that I speak English, but I've learned that watching movies, so I have no proper English learning, and actually that was one of the most difficult things to overcome. But if you keep on showing up, if you know that, if you show that you are motivated, that you are eager to learn, by the end of the day, they will see that and they will respect that. It doesn't happen from day one to day two. It took me three months at least to really be settled in the team, and not be just considered as a visitor, because I think there are a lot of people who come here 1 month to visit, to see a little bit of trauma and say, okay, I done my global surgical rotation. And that's not, I think they miss a big part, because you need at least 6 months. Otherwise you can't comprehend the intricacy of the setting, how the hospital works, even the feelings between the teams. So it takes a long time, but after 3 months, I think when you put the effort, when you show respect, when you show that you are not there to go there as a cowboy, and you are humble and you are willing to learn, they will integrate you as part of the team. And by the end of my rotation in Cali, I was doing my calls alone. I was operating with the consultant, which was great. One of my most beautiful procedure was the repair of an IVC, which we know is kind of the worst injury. And here also, step by step, I got into the team, but obviously it's difficult, and it's all about the journey. Actually, it's all about how much you will learn about yourself, how much you will strengthen your soft skills. And you mentioned the one-to-one relationship you can create, and this can be very valuable because they can change your experience completely. When you find one mentor, when you find one person of reference that will guide you through the process, that's sometimes enough. And I can only encourage you to do it, to take the leap, because you will gain so much from it. It was difficult at some times in the beginning. Even if I speak Spanish at home, the medical language is not the common language, and that's the same in English. So it's like everything in life. You have to fight a little bit for it, but with perseverance, you will get through it.
There are two questions here, one from Mexico and the other one, I'm not sure from what part of the world, but it appears that it's far away from Mexico. And both of them seem to have you ask you to expand a little bit to, okay, now that you're back and you have gained all this experience, how would you turn these into changing the health system? And the specific question was, do you have access to a trauma registry in these places? Were you able to look at data to begin to ask questions about quality of care or perhaps surgical outcomes? How difficult it is to turn these into a more structured methodology for actually improving healthcare systems based on some research evidence? It's a tough question, by the way.
It's a tough question, and I won't pretend. I will stay modest here, because I think each setting face their own reality and their own challenges. I'm not going to be the one who's going to change and make everything better. But I know that when going back to Belgium, I have a logbook to give. So I've noted my operations. In Cali, they use both paper and the computers. It's the same in South Africa, but I think it's gonna change because you have a lot of information lost. But in Cali, they have a very good trauma registry. In South Africa also, I would like to do some research and strengthen our collaboration. So I will be able to give you some answer in the future, and I hope that we will be able to publish something, and then you will see that trauma registry are actually very beneficial for this collaboration, because it can really show on paper all you can get from it. And actually in Belgium, we are when I ask for our own record, we are only beginning now. So we can think, oh, we are come from a high income country, but actually for trauma, we are also at the beginning. So I've learned a lot about the trauma registries in Cali, and that's something I would like to take home. And if I'm allowed to, I obviously would like to improve both systems. I will be happy to collaborate in any way I can.
There is a question here for Catherine, Dr. Xu. Perhaps because of some of the language limitations, I think there are several members of COSEXA who have listened to the seminar, and they are saying, well, if I wanted to improve my exposure to trauma, I probably will have to find an English-speaking country. And then after Isadora's presentation, obviously, Stellenbosch is on the spotlight. So how would you guide these other English-speaking African surgeons who want to expand? Not there are many places in Africa that are not as violent, may not have that volume that you have in Cape Town. Tell us a little bit of how would you guide these African surgeons who want to enhance their exposure to trauma?
So there are actually
already... Thank you for the question.
Sorry, it was for Catherine. I'm sorry, Catherine.
It's a question for Catherine. You can comment after that, Isadora.
It's fine.
Yeah, so I mean, I think that first of all, Stellenbosch welcomes African trainees. They welcome trainees from all over the world. But in particular, I think that Stellenbosch University has a particular interest in improving the capacity of healthcare workers on our own continent. So we definitely welcome COSEXA surgeons. I think that Stellenbosch and the Tygerberg Hospital, specifically our training hospital, does have quite a lot of applications for people coming, but there is a formal system. The main hurdle or the challenge is to get to the South African Medical Council registration. So Isadora can probably tell us a little bit more about that. But I do think that that's quite important, because without that, one can only observe. And with the registration, there's the chance to scrub in and participate in the operations, which I think as a surgeon or a surgical trainee will benefit one a lot more. The other thing, of course, is the amount of time that can be taken to come. So, you know, if you come for 1 month, 2 months, most people in a busy trauma setting will kind of just not ignore you, but not really see you as meaningfully contributing, which means that if they're trying to deliver a service to a patient, they might not necessarily include you. Whereas if you stay longer, I think Dr. Isadora did say that took her 3 months to really get sort of the trust and buy-in of people. And so that would be important. Now, the cost of living in South Africa, however, is often a concern, especially for African trainees, because we do cost more than to live, and we don't offer sort of paid positions here, if you will, if you're not South African. That being said, through COSEXA, there have been sponsored fellowships now. So COSEXA has partnered with several organizations, for example, Smile Train or Operation Smile, for plastic surgery fellowships. And at Tygerberg, as well as other South African hospitals, there are fellowships in trauma. So if COSEXA were able to get sponsors from other NGOs or private organizations for COSEXA surgeons to come down and do a formal fellowship in trauma, and there was funding for them to come, I think that would be a wonderful and sustainable collaboration, because then they would also sort of be recognized having done a formal fellowship, and would be able to get some financial support. Did you also want to say something on that, Dr. Isadora?
Well, I have one more question. This one probably needs to be answered by both of you, because come from two women who are young women aspiring to be a surgeon, one from Nicaragua and the other one from Uruguay. And they say, what advice would you give a young woman aspiring to be a surgeon? So please, both of you answer these questions if you may.
I think Dr. Isadora, you qualify as young. So why don't you go?
Okay, that's a tough question because I haven't figured it out myself. I'm just gonna say that with work ethic, you will get through everything. It's a rough path because it's still there are still challenges in surgery. I think it's slightly improving. I personally have faced these challenges, but you get stronger with the time. I don't know if it's the right answer. That's the one I personally experience. You just have to pull through. And when I say surround yourself with a strong community and with mentors, with the right kind of mentors, I think that's the key to success. Don't let the system get into your head, because when you know your why, you will figure out your how. That's really what I've learned here. Is I know I wanted to do that as a trauma surgeon, but in Belgium, I was often told that I have no career waiting for me there, but I still persevered, and now I can give this webinar and share my experience, and it's a very humbling one, but maybe it's the beginning of other things. So my advice would say, you just have to really know your why you do it. Do it for the right reason, and surround yourself with a good community, with good mentors, and you will get through it.
Thank you. I was going to close here, but two questions popped up, and they want to know what it's like to be exposed to intensive care training as a surgeon. Even though in the United States, myself as a trauma surgeon, we do acute care surgery and critical care, the presence of the surgeon in the ICU as a full-time ICU attending is not common around the world, definitely not in Europe, and only in a few places in Latin America. So how would you begin to change that kind of practice, which I think will be rather difficult in some places in Europe? And the question is, advice about incorporating what you learned in the ICU when you move back to anywhere in Europe, perhaps?
That's an excellent question. And that's really something I want to develop further for my own knowledge, because I was impressed by all the trauma surgeon here and in Cali. They can do everything. They can deal with the complication. They can deal with the primary assessment. That was very impressive. And when I started my career, when I wanted to do global general surgery, it was with that goal in my head. Like, I want to be able to have a patient and take care of him from the beginning to the end. So the ICU is a very important part of the training. I will have to see how I can improve further in that, because I don't have the skills that my fellow colleagues here in South Africa or in Colombia have, because they rotate through that. But I think it would be interesting to integrate that in our residency program in Belgium, and maybe I can advocate for it and try to do it. Also, like, fashion my little way around it and try to do a rotation, because I think it's of great value for the surgeon.
Thank you. Okay, we seem to have come almost the end of the hour. I'm going to take the liberty of two sort of closing remarks. And first of all, thank Isadora for your wonderful presentation. And of course, thank Dr. Chu, not only for being here with us today, but for welcoming Isadora at your hospital there in Cape Town. As someone that have dedicated all my life to trauma, and I have been originally born in Colombia, I'm tremendously proud of you showing how good the Colombian surgeons are. I think that that's one of the things that moved me into international collaborations, because trauma has learned a lot from Colombians. The Bogota bag was a contribution from Dr. Borraes. When Dr. Feliciano came to Bogota, this is before Rotondo had talked about abdominal compartment syndrome and damage control. The Colombians were already leaving abdomens open. And then Alberto Garcia introduced the damage control in severe pulmonary injuries and the perfect outcome, or not perfect, but the very good outcomes in pneumonectomy. So this is music to my ears to see that everywhere in the world, no matter where you belong, in the north, in the south, to the left, to the right, you can learn from each other. And there is a lot to learn from those who have tremendous skills, and they get to do better work because they have no resources whatsoever. So thank you all for joining us today in webinar. As I mentioned at the beginning of the webinar, this presentation has been recorded and will be posted in the American College of Surgeons YouTube page. You may also view past webinars on the American College YouTube page under the Global Surgery playlist. Don't forget, if you have ideas and you think you want to bring a group of panelists to talk about anything else, the staff at the International Committee and at the American College will be more than happy and welcoming to bring your ideas. Lastly, today's webinar was about residence experience. I would also like to highlight that this year's residents can become a member of the American College of Surgeons. And if you have any questions, you'll be able to contact Jesse, who we thank tremendously for all the help. Jesse, back to you. Do we close? Do we say goodbye? I don't know if you want to say anything.
Thank you, Dr. Puyana, Dr. Frick, and Dr. Chu, and everyone for joining us today. With that, we will conclude today's webinar and be on the lookout for when it goes to our YouTube page. Thank you. Have a nice day. Bye-bye, everyone.
Thank you. Thank you very much.